Morning everyone, and welcome to pharmacology class. Today topics is drugs used in heart failure, and heart failure occurs when cardiac output is inadequate to provide the oxygen needed by the body. It is a highly lethal condition with a 5-year mortality rate conventionally set at about 50%. The most common cause of heart failure is coronary artery disease, with hypertension also an important factor. Two major types of failure may be distinguished. Approximately 5% of young patients have systolic failure with reduced mechanical pumping action and reduced ejection fraction. The remaining 50% has diastolic failure, which stiffening and loss of adequate relaxation playing a major role in reducing feeling and cardiac output. Ejection fraction may be normal even with stroke volume is significantly reduced. The proportion of patients with diastolic failure increases with age because other cardiovascular conditions are now being treated more effectively. More patients are surviving long enough for heart failure to develop, making heart failure one of the cardiovascular conditions that is actually increasing in prevalence. Heart failure is a progressive disease that is characterized by a gradual reduction in cardiac performance, punctured in many cases by episodes of acute decompensation, often requiring hospitalization. A treatment is therefore directed at two different goals. First is reducing symptoms and slowing progression as much as possible during relatively stable periods. And second, managing acute episodes of decompensated failure. Although it is believed that the primary defect in early systolic heart failure resides in the excitation-contraction coupling machinery of the heart, the clinical condition also involves many other processes and organs, including the baroreceptor reflex, the sympathetic nervous system, the kidneys, angiotensin II and other peptides, aldosterone, and apoptosis of cardiac cells. Recognition of these factors has resulted in evolution of a variety of drug treatment strategies. So here the pharmacological groups of drugs are listed for the treatment of the chronic heart failure and acute heart failure. So for the chronic heart failure, diuretics are aldosterone receptor antagonists, angiotensin converting enzyme inhibitors, and angiotensin receptor blockers, as well as beta blockers, cardiac glycosides, Digoxin and Digitoxin, and vasodilators are used. For the acute heart failure, diuretics, but the intravenous one, so the furosemide for example, and then vasodilators like sodium nitroprusside, and then beta agonists are used versus the beta blockers during the chronic heart failure, and also bipyridines and natriuretic peptides are useful. Large clinical trials have shown that therapy directed at non-cardiac targets is more valuable in the long-term treatment of heart failure than traditional positive inotropic agonists. like cardiac glucosides, for example, digitoxin. Extensive trials have shown that angiotensin-converting enzyme inhibitors and angiotensin receptor blockers, as well as beta blockers and aldosterone receptor antagonists and combined hydralazine nitrate therapy, are the only agents in current use that actually prolong life in patients with chronic heart failure. These strategies are useful in both systolic and diastolic failure. A positive inotropic drug, on the other hand, are helpful mainly in acute systolic failure. Cardiac glucosides also reduce symptoms in chronic systolic heart failure. Other positive inotropic drugs have consequently reduce survival in chronic failure, and their use is discouraged. The vigor of contraction of heart muscle is determined by several processes that lead to the movement of actin and myosin filaments in the cardiac sarcomere. So this is a schematic of the cardiac sarcomere, and so this is one sarcomere, and ultimately contraction results from the interaction of activated calcium with the actin-tropomyosin system, thereby releasing the actin-myosin interaction. This activated calcium is released from the sarcoplasmic reticulum. So, calcium is released from the sarcoplasmic reticulum that activates the actin-tropomyosin and myosin chains to slice. The amount released depends on the amount stored in the sarcoplasmic reticulum and on the amount of free calcium that enters the cell during the plateau of the action potential. So, amount of this calcium actually determines how much calcium is released here. The determinants of calcium sensitivity are it as the curve relating the shortening of cardiac myofibrils to the cytoplasmic calcium concentration are incompletely understood, but several types of drugs can be shown to affect calcium sensitivity in vitro. Levosimendan is the most recent example of a drug that increases calcium sensitivity and reduces symptoms in models of heart failure. The recent report suggests that an experimental drug, omecamtiv mecarbil, that is CK182752, alters the range of transition of myosin from a low actin binding state to a strongly actin bound force-generating state. Preliminary studies in experimental animal models of heart failure indicate that this agent may provide a new approach to the treatment of heart failure in humans. So clinical trials are underway. A small rise in free cytoplasmic calcium brought about by calcium influx during the action potential triggers the opening of calcium-gated ryanodine-sensitive calcium channels. And So, these radiolentine uh, sensitive calcium channels are opened, and the calcium goes uh, to the cytoplasm, uh, and this release uh, activates the actin troponin tropomyosin complex. The amount released is proportional to the amount stored in the sarcoplasmatic reticulum and the amount of free calcium that activates the cell through the cell membrane. The sarcoplasmatic reticulum membrane contains a very efficient calcium uptake transporter known as the sarcoplasmatic reticulum uh, and ATPase. This pump maintains free cytoplasmic. So this is the receptor. This receptor maintains free cytoplasmic calcium at very low levels during diastole by pumping calcium into the sarcoplasmatic reticulum. The sarcoplasmatic endoplasmic reticulum calcium at the ATPase is normally inhibited by phospholamban. Phosphorylation of phospholamban by protein kinase A removes this inhibition. The amount of calcium sequestrated in the sarcoplasmatic reticulum is thus determined in part by the amount accessible to this transporter and the activity of sympathetic nervous system. This in turn is dependent on the balance of calcium influx and calcium efflux and the amount removed from the cell. The amount of calcium released from the sarcoplasmatic reticulum depends on the response of the ryanodine channels to trigger calcium. The amount of triggered calcium that enters the cell depends on the availability of membrane calcium channels and the duration of their opening. The sympathomimetics cause an increase in calcium influx through an action on these channels. Conversely, the calcium channel blockers reduce this influx and depress contractility. So calcium channel blockers and beta agonists will increase the calcium that enters the cell. The antiporter uses the sodium gradient to move calcium against its concentration gradient from the cytoplasm to the extracellular space. Extracellular concentrations of these ions are much less liable than intracellular concentrations under physiological conditions. The sodium-calcium exchange ability to carry out this transport is thus strongly dependent on the intracellular concentration of both ions, especially sodium. Intracellular sodium concentration dependent on the activity of the sodium potassium ATPase. By removing intracellular sodium, this enzyme is the major determinant of sodium concentration in the cell. The sodium influx through the voltage-gated channels, which occurs as a normal part of almost all cardiac action potentials, is another determinant, although the amount of sodium that enters with each action potential is much less than the 1% of the total intracellular sodium. Sodium potassium ATPase appears to be the primary target of digoxin and other cardiac glycosides. Heart failure is a syndrome with many causes that may involve one or both ventricles. Cardiac output is usually below the normal range, and systolic dysfunction with reduced cardiac output and significantly reduced ejection fraction is typical of acute failure, especially that resulting from myocardial infarction. Diastolic dysfunction often occurs as a result of hypertrophy and stiffening of the myocardium, and although cardiac output is reduced, ejection fraction may be normal. Heart failure due to diastolic dysfunction does not usually respond optimally to positive inotropic drugs. High output failure is a rare form of heart failure. In this condition, the demands of the body are so great that even increased cardiac output is insufficient. High output failure can result from hypothyroidism, beriberi, anemia, and arterial or venous shocks. This form of failure responds poorly to the drug discussed and should be treated by correcting the underlying cause. The primary signs and symptoms of all types of heart failure include tachycardia, decreased exercise tolerance, shortness of breath, and cardiomegaly, peripheral and pulmonary edema, and often, but not always, congestion of heart failure is present. Decreased exercise tolerance with rapid muscular fatigue is the major direct consequence of diminished heart output. The other manifestations result from the attempts by the body to compensate for the intrinsic cardiac defect. The neurohumeral compensation involves two major mechanisms: the sympathetic nervous system and the renin-angiotensin-aldosterone hormone. The baroreflector reflex appears to be present with a low sensitivity to arterial pressure in patients with heart failure. As a result, baroreceptor sensory input to the vasomotor center is reduced even at normal pressures. Sympathetic outflow is increased and parasympathetic outflow is decreased. Increased sympathetic outflow shown here causes tachycardia and increased contractility and increased muscular tone. Vascular tone is further increased by angiotensin II and endothelium. A potent vasoconstrictor released by vascular endothelium cells. Vasoconstriction increases afterload and which further reduces ejection fraction and cardiac output. The result is a vicious cycle that is characteristic of heart failure. Neurohumeral antagonists and vasodilators reduce heart failure mortality by interrupting the cycle and slowing the downward spiral. After a relatively short exposure to increased sympathetic drive, complex down-regulatory changes in the cardiac beta-1 adrenal receptor G protein effector system take place that result in diminished stimulatory effects. Beta-2 receptors are not down-regulated and may develop increased coupling to the inositol 3-phosphate and deacyl cascade. It has also been suggested that cardiac beta-3 receptors, which do not appear to be down-regulated in failure, may mediate negative inotropic effects. Excessive beta activation can lead to leakage of calcium from sarcoplasmatic reticulum and contributes to stiffening of the ventricles and arrhythmias. Prolonged beta activation also increases uh, caspase, the enzymes responsible for apoptosis. Increased angiotensin II production leads to increased aldosterone secretion, to increased afterload, and to remodeling of both heart and vessels. Other hormones are released, including natriuretic peptide, endothelin, and vasopressin. Within the heart, failure-induced changes have been documented in calcium handling in the sarcoplasmatic reticulum and phospholamban in transcription factors that lead to hypertrophy and fibrosis in mitochondrial function, which is critical for energy production in the overworked heart, and in ion channels, especially potassium channels, which facilitate erythrogenesis, a primary cause of death in heart failure. Phosphorylation of ranitidine channels in the sarcoplasmatic reticulum enhances and dephosphorylation reduces calcium release. Studies in animal models indicate that the enzyme primarily responsible for ranitidine dephosphorylation, protein phosphatase 1, is upregulated in heart failure. These cellular changes provide many potential targets for future drugs. The most important intrinsic compensatory mechanism is myocardial hypertrophy. This increase in muscle mass helps maintain cardiac performance. However, after an initial beneficial effect, hypertrophy can lead to ischemic changes, impairment of diastolic filling, and alterations in ventricular geometry. Remodeling is the term applied to dilation and other slow structural changes that occur in the stressed myocardium. It may include proliferation of connective tissue cells as well as abnormal myocardial cells with some biochemical characteristics of fetal myocytes. Ultimately, myocytes in the failing heart die at an accelerated rate through apoptosis, leaving the remaining myocytes subject to even greater stress. Cardiac performance is function of four primary factors: preload, when some measure of left ventricular performance such as stroke volume or stroke work is plotted as a function of the left ventricular filling pressure or end-diastolic fiber length. The resulting curve is termed the left ventricular function curve. The ascending beam represents the classic Frank-Starling relation described in physiology texts. Beyond approximately 15 millimeters of hierarchy, there is a plateau of performance. So this here is a plateau of performance, and this is ascending limb. Preloads greater than 20-25 millimeters of high grade beam result in pulmonary congestion. So this is congestion area. Uh, Preload is usually increased in heart failure because of increased blood volume. Uh, and also increased venous tone. Because the function curve of the failing heart is lower, the plateau is reached at much lower values of stroke work or output. Increased fiber length or a filling pressure increases oxygen demand in the myocardium. Reduction of high filling pressure is the goal of salt restriction and diuretic therapy in heart failure. Venodilated drugs, for example nitroglycerin, also reduce preload by redistributing blood away from the chest into peripheral veins. Afterload is the resistance against which the heart must pump blood and is represented by aortic impedance and systemic vascular resistance. Uh, uh, Afterload afterload will be increased because of the reflex increase in systemic vascular resistance, mediated in part by increased sympathetic outflow and circulating catecholamines, and in part by activation of renin and angiotensin aldosterone system. So sympathetic discharge increases the renin, then it increases angiotensin, this increases the afterload. Endothelin, a potent vasoconstrictive peptide, is also involved. This sets the stage for the use of drugs that reduce arteriolar tone in heart failure. Contractility, the heart muscle obtained by biopsy from patients with chronic low output failure, demonstrates a reduction in intrinsic contractility. As contractility increases in the patient, there is a reduction in the velocity of muscle shortening, the rate of intraventricular pressure development, and the stroke output achieved. So the stroke is decreased. However, the heart is usually still capable of some increase in all these measures of contractility in response to inotropic drugs. So usually this. And the last one is heart rate. The heart rate is a major determinant of cardiac output, as the intrinsic function of the heart decreases in failure and stroke volume diminishes. An increase in heart rate through sympathetic activation of beta adrenal receptors is the first compensatory mechanism that comes into play to maintain cardiac output. The most effective of the drug that have been used for a long time is the Digitalis. And Digitalis is the name for the family of plants that provide most of the medically useful cardiac glycosides, for example, Digoxin. Such plants have been known for thousands of years, but were used erratically and with variable success until 1785, when William Withery, an English physician and botanist, published a monograph describing the clinical effects of an extract of the purple foxglove plant, that is Digitalis purpurea, a major source of these agents. All of the cardiac glycosides or cardinalides, of which digoxin is the prototype, combine a steroid nucleus linked to lactone ring. So this is lactone ring and this is a steroid nucleus. So they are linked at position 17 and a series of sugars at carbon 3 of the nucleus. 1, 2, 3. Because they lack an easily ionizable group, their solubility is not pH dependent. And digoxin is obtained from Digitalis lanata, the white foxglove, but many common plants contain cardiac glycosides with similar properties, including the lily of the valley, milkweed, and leander. Digoxin, the only cardiac glycosides are used in most of the countries, is 65–80% absorbed after oral administration, so good bioavailability. Absorption of other glycosides varies from 0 to nearly 100%. Once present in the blood, all cardiac glycosides are widely distributed to tissues, including the central nervous system. Digoxin is not extensively metabolized in humans. Almost two-thirds is excreted unchanged by the kidneys. Its renal clearance is proportional to creatinine clearance, and the half-life is 36 to 40 hours in patients with normal renal function. Equations and nomograms are available for adjusting digoxin dosage in parents with renal impairment. Digoxin has multiple direct and indirect cardiovascular effects with both therapeutic and toxic consequences. In addition, it has undesirable effects on the central nervous system and gut. At the molecular level, all therapeutically useful cardiac glycosides inhibit potassium or sodium-potassium ATPase, the membrane-bound transporter that that is often called the sodium pump. Although several isoforms of these ATPase occur and have varying sensitivity to cardiac glycosides, they are highly conserved in evolution. Inhibition of this transporter over most of the dose range has been extensively documented in all tissues studied. It is probably that this inhibitory action is largely responsible for the therapeutic effect, that is, positive inotropic action, as well as a major portion of the toxicity of the digitalis. Other molecular level effects of digitalis have been studied in the heart and are discussed later. The fact that a receptor for cardiac glycosides exists on the sodium pump has prompted some investigators to propose that an endogenous digitalis-like steroid, possibly hubain or marinobufuranine, must exist. There are furthermore additional function of sodium-potassium ATPase have been postulated involving apoptosis, cell growth and differentiation, immunity, and carbohydrate metabolism. So the cardiac effects of the cardiac glycosides include mechanical effects. Cardiac glycosides increase contraction of the cardiac sarcomere by increasing the free calcium concentration in the vicinity of the contractile proteins during systole. The increase in calcium concentration is the result of a two-step process. First, an increase of intracellular sodium concentration because of the sodium-potassium ATPase inhibition, and second, a relative reduction of calcium expulsion from the cell by the sodium-calcium exchange. So these two enzymes are involved. And the increased cytoplasmic calcium is sequestrated by the sarcoplasmic reticulum for later release. Other mechanisms have been proposed but are not well supported. The net results of the action of therapeutic concentrations of a cardiac glycoside is a distinctive increase in cardiac contractility. So in isolated myocardial preparations, the rate of development of tension and of relaxation are both increased, with little or no change in time to peak tension. This effect occurs in both normal and failing myocardium, but in the intact patient, the responses are modified by cardiovascular reflexes and the pathophysiology of heart failure. So the second is electrical effects. The effect of digitalis on the electrical properties of the heart are a mixture of direct and autonomic actions. Direct actions on the membranes of cardiac cells follow a well-defined progression: early brief prolongation of the action potential followed by shortening. The decrease in action potential duration is probably the result of increased potassium conductance that is caused by increased intracellular calcium. All these effects can be observed at therapeutic concentrations in the absence of overt toxicity. At higher concentrations, resting membrane potential is reduced as a result of inhibition of the sodium pump and reduced intracellular potassium. As toxicity progresses, oscillatory depolarizing after potentials appear following normally evoked action potentials. The after potentials, also known as the late after potentials, are associated with overloading of the intracellular calcium stores and oscillations in the free intracellular calcium ion concentration. When after potentials reach a threshold, they elicit action potentials, that is premature depolarizations, that are coupled to the preceding normal action potentials. If after potentials in the Purkinje's conduction system regularly reach threshold in this way, meaning will be recorded on the electrocardiogram. With further intoxication, each after potential evoked action, potential will itself elicit a suprathreshold after potential, and self-sustaining tachycardia will develop. If allowed to progress, such a tachycardia may deteriorate into fibrillation. In the case of ventricular fibrillation, the arrhythmia will be rapidly fatal unless corrected. Autonomic actions of cardiac leukocytes on the heart involve both the parasympathetic and the sympathetic systems. In the lower portion of the dose range, cardioselective parasympathomimetic effects predominate. In fact, these atropine blockable effects account for a significant portion of the early electrical effects of digitalis. These actions involve sensitization of the baroreceptors, central vagal stimulation, and facilitation of muscarinic transmission at the cardiac muscle cell. Because cholinergic innervation is much rich in the atria, these actions affect as well and atrioventricular nodal function more than Purkinje or ventricular function. Some of the cholinomimetic effects are useful in the treatment of certain arrhythmias. At toxic levels, sympathetic outflow is increased by digitalis. This effect is not essential for typical digitalis toxicity, but sensitizes the myocardium and exaggerates all the toxic effects of the drug. The most common cardiac manifestations of digitalis toxicity include atrioventricular junctional rhythm, premature ventricular depolarizations, bigeminal rhythm, and second-degree atrioventricular blockade. However, it is claimed that digitalis can cause virtually any arrhythmia. Cardiac leukocytes affect all excitable tissues, including smooth muscle and the central nervous system. The gastrointestinal tract is the most common site of digitalis toxicity outside the heart. The effects include anorexia, nausea, vomiting, and diarrhea. This toxicity is caused in part by direct effects on the gastrointestinal tract and in part by central nervous system actions. Central nervous system effects include vagal and chemoreceptor trigger zone stimulation, less often disorientation and hallucination, especially in the elderly, and visual disturbances are noted. The latter effect may include aberrations of color perception. Gynecomastia is a rare effect reported in men taking digitalis. Potassium and digitalis interact in two ways. First, they inhibit each other's bonding to potassium, sodium-potassium ATPase. Therefore, hyperkalemia reduces the enzyme inhibiting action of the cardiac leukocytes, whereas hypokalemia facilitates these actions. Second, abnormal cardiac automaticity is inhibited by hyperkalemia. At moderately increased intracellular calcium therefore reduces the effects of digitalis, especially the toxic effects. Calcium ion facilitates the toxic action of cardiac leukocytes by accelerating the overloading of intracellular calcium stores that appears to be responsible for digitalis-induced abnormal automaticity. Hyperkalemia therefore increases the risk of digitalis-induced arrhythmia. The effects of magnesium ion are opposed to those of calcium. These interactions mandate careful evaluation of serum electrolytes in patients with digitalis-induced arrhythmias. So we will stop here and thank you for attention, and if you have any suggestions or comments, please feel free to leave them below. Thank you very much for attention and see you next week.